My name is Brendan O'Connell. I'm an assistant professor of otology and neurotology at the University of North Carolina, Chapel Hill. And today, I'm going to be talking about surgical decision making that can improve outcomes after cochlear implantation. I want to acknowledge our cochlear implant teams at both the University of North Carolina and Vanderbilt, where much of this work had been done. Specifically, I want to acknowledge Jack Noble, Rob Labadie, and George Wana, David Haynes for their assistance with these projects. So we all know that indications for implantation have expanded greatly over the past 10 to 15 years. This now includes patients with audiograms, as such you can see here, significant low frequency residual hearing. We've always sought to achieve better speech perception outcomes, but as we're seeing more and more patients with this configuration of an audiogram, our goals now have shifted. We're attempting to preserve structure and hearing through minimization of trauma to fine cochlear structures. So there's various mechanisms of trauma. You can drill on the cochlea, that's direct trauma. Acute non-mechanical injuries, so acoustic trauma from a drill or mixing of fluids inside the cochlea once the round window's been opened. And then there's delayed or subacute events like fibrosis or inflammation. Many of these are hard to measure and assess, but one in which we can now examine in vivo, starred here in the blue portion of the graph, is misdirection of an electrode into the scala vestibuli from the scala tympani. So let's think about that a bit further. So ideally, an electrode is meant to be inserted fully within the scala tympani. This is a 3D reconstruction using Vanderbilt software that demonstrates an electrode entirely within the red scala tympani compartment on the left. We defined a scala tympani insertion as one in which every contact was located within the scala tympani. On the right, you can see an example of crossover into the scala vestibuli. Here you can see that the electrode punctures through the basilar membrane, exits the red compartment, and enters the blue scala vestibuli. So looking at how crossover may impact speech perception outcomes, we've plotted CNC score on the left portion of this graph and AZ Bio score on the right portion of this graph in relation to scalar placement. So you can see that the red bars, the scala tympani insertions, are associated with about a 10 to 15 percentage point advantage in speech perception when compared to the blue bar, the scala vestibuli insertion. Shifting gears a bit, if we look at hearing preservation, we looked retrospectively initially at patients and divided them into either a scala tympani or a scala vestibuli insertion. We then looked at hearing preservation as a dichotomous outcome defined as maintenance of 80 dB at 250 or better. And what we found was that for electrodes inserted entirely within the scala tympani, our hearing preservation rates were almost 60%. For electrodes that crossed over into the scala vestibuli, we observed 0% hearing preservation. There are limitations to the retrospective nature of the study. Therefore, we now have prospective data looking at the same thing. So when we divide patients according to where the electrode is and look at PTA shift, so PTA shift here is on the y-axis, greater PTA shift indicates worse hearing preservation. We saw that the mean PTA shift for a scala tympani insertion was roughly 20 dB compared to 40 dB for a scala vestibuli insertion, and this difference was significantly different. So why would a scala tympani insertion be better than a scala vestibuli insertion? Well, for one, a scala vestibuli insertion is going to inherently cause trauma to inner ear structures. Then if we think about what spiral ganglion cells we're stimulating, if you look at a scala tympani electrode there on the right, and the red arrow points to the spiral ganglion cells, it's going to be stimulating the spiral ganglion cells in that immediate cochlear turn. If you look at a scala vestibuli placement, there's the potential that it will stimulate spiral ganglion cells not only in that same turn, but also the next most apical turn, and this could potentially cause pitch confusion. So conclusions from this first portion of the study are that scala tympani insertions are clearly associated with better speech perception and hearing preservation outcomes. But now we have to think about what we can do as surgeons to maximize our ability to achieve a scala tympani insertion. So let's look at surgical factors. So we choose the electrode that we put into each patient. And here, the graph on the right depicts speech perception outcomes according to electrode design. So LW is a lateral wall or a straight electrode, PM is perimedialar, and MS is mid-scala. If you look at the size of the red bar, that's going to show you how many patients achieved a scala tympani insertion in each of those electrode cohorts. So almost all the patients in the straight or lateral wall group had electrodes placed entirely within the scala tympani. Compare this to roughly a 50% crossover with both perimedialar or mid-scalar arrays. When this was examined in multivariate fashion, controlling for all other variables, we demonstrated a 22 times higher likelihood of correct placement when a lateral wall electrode was used. Now thinking about hearing preservation, we examined how electrode design impacted hearing preservation rates. Again, looking at functional hearing preservation as a dichotomous outcome of achievement of 80 dB at 250 or better. And what we found was that a lateral wall electrode was associated with an 8 times higher likelihood of achieving functional hearing preservation when compared to a pre-curved array. So thinking about surgical approach. So when we insert an electrode into the cochlea, we can put it either directly through the round window, that's a round window insertion. We can find the round window and enlarge it slightly, that would be an extended round window approach. Or we can drill an opening into the cochlea that's entirely separate from the round window membrane, that would be a cochleostomy. And this is a similar graph to what we've seen before, but if we separate patients into either round window, extended round window, or cochleostomy approaches, we see significant differences in the ability and the rate of achievement of a scala tympani insertion. Specifically, we see a 70% reduction in crossover when either a round window or an extended round window approach are used. We also looked at approach and its impact on hearing preservation. While it didn't impact short-term hearing preservation rates, when we looked out beyond 1 year, we did find that a round window approach was associated with better long-term hearing preservation. This goes along with data that has recently demonstrated that there's some fibrosis or intracochlear reaction that can occur with the cochleostomy that may not result in immediate hearing loss, but potentially delayed hearing loss. So why would a round window approach confer hearing preservation benefit or even speech perception benefit? This is a microscopic view of a right ear. This has been provided by Jack Noble. The blue arrow points to the incus buttress. The green arrow points to the IS joint, and the red arrow points to the round window niche near the round window membrane. If we then translate that into a virtual view and superimpose the scala, so again, scala tympani is in red, scala vestibuli is in blue, and there the round windows in yellow. You can see that where on that arc of the round window you decide to make an opening is going to impact the likelihood of having it stay within the red or the blue compartments. This is highlighted by a survey study in which surgeons were polled and asked where they made their cochleostomy. And you can see, if you think back to that prior graph, you want to be inferior or antero-inferior. And if we look at this picture again, that's going to be your I or your AI. And we look at the percentage of surgeons saying that they'd make either an anterior or a superior cochleostomy is roughly 50%. And that again is going to predispose to either early translocation or even direct insertion into the scala vestibuli. So thinking about depth of insertion, I think it's critical that we use angular depth measurements and not linear depth measurements. Angular insertions take into account variance in both cochlear size and electrode length. So here is a depiction of how we measure angular insertion depth. So you draw a line from the center of the round window where the green arrow is to the medialis. And then anything in the first turn is 360 degrees, and anything in the second turn is going to be up to 720 degrees. This graph doesn't look pretty, but there is a correlation there, and that's because there's multiple factors, again, that go into outcomes and performance. So CNC score is on the y-axis and depth is on the x-axis. But when you put this into a multivariate model, controlling for those other variables that we know and have already shown to impact outcomes, you do see a highly significant correlation. Specifically, we see that CNC score increases 1% for every 15-degree increase in insertion depth. So if there's a 200-degree difference, which there can be, of insertion depths within individual electrode cohorts, that can account for up to 10 to 13% difference in CNC score. So knowing that straight arrays and round window approaches are going to maximize the likelihood of being in the correct place, we then looked at a cohort of these patients to specifically examine insertion depth and outcomes within this group. So this includes 24 millimeter electrodes, 28 millimeter electrodes, and 31 millimeter electrodes. And as you can see here, the further you move to the right on the graph, so a greater insertion depth, the better the CNC score. And this relationship was highly significant with a good correlation, 0.57. Why would this be? Obviously, a deeper insertion increases the coverage of the cochlea, and we think that this is going to extend the range of pitch percepts available to the patient, and will also result in a better frequency match with the natural tonotopic organization of the cochlea. But we have to balance this. As I said at the beginning, we're seeing patients with greater degrees of residual hearing. So when we think about hearing preservation, it makes sense that the deeper the electrode is, the further it is, closer it is to the apical region, the low frequencies, the more likely we will be to lose hearing. And I think a number of studies have shown that, and this is our data from UNC that also demonstrates better hearing preservation with shorter electrodes. So you can see that the mean PTA shift, again, a lower number here is better. The mean PTA shift with Flex 24 was 20 dB. With Flex 28 was roughly 25 to 30 dB. And with the standard it was almost 40 dB, and those differences were significant. So in conclusion, I hope I've demonstrated and shown some data that reveals the importance of a scaleotympany insertion, i.e. a scaleotympany insertion is associated with, independently predictive of, better speech perception and hearing preservation outcomes. And then when we're thinking about decisions that we can make to increase our likelihood of a scaleotympany insertion, we should give strong consideration to the use of lateral wall electrodes inserted through either round window or extended round window approaches. This has to be balanced though. When we think about how far to put an electrode in, we know that deep insertions in the electric-only condition are associated with better speech outcomes. We have to think about the fact that a deeper insertion is going to convey worse hearing preservation results. And I think as we move forward as a field, we need to really consciously encourage and ourselves and our colleagues to measure insertion depth angles and use this to generate plans by which we can individualize and customize insertions to individual patients. Thank you very much.